You're listening to the Primary Care PT podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Stay tuned and subscribe. Okay, hello everybody. Happy December if you're listening to this in December. If you're not listening to it in December, happy whatever month you're listening to this in, month, year. So today it's actually been a number of episodes since I've interviewed somebody from a different primary care clinic. So I am excited today to have a special guest from the lovely state of Washington, who can tell us a little bit more about the setting that she works at. Washington, right? I didn't get
That's
that wrong.
correct.
It's okay.
Yes.
I thought so. Sometimes I get the some of the primary care clinics in Oregon and Washington, but I thought it was Washington. So we have Rachelle here today, and she's going to tell us a little bit about the setting that she works in. So Rachelle, thank you so much for coming on the show today.
Oh, thank you for inviting me.
Yeah. And so why don't you tell us just a little bit about yourself and your background, and then we can talk a little bit about the primary care clinic that you work in.
Sounds good. I am a physical therapist who has been practicing for a little over 25 years now and have spent most of my time in the outpatient setting, treating general musculoskeletal conditions, and also I'm a pelvic health specialist. So that would be treating, chronic pain of the pelvis, incontinence, those type of things. I grew up in a family where holistic healthcare was just the way things were. You worked on preventing illnesses and a decreased focus on medications, and reactionary treatments were always seen as a bad thing. Why don't we try to catch it upstream? And so when I learned about primary care PT, I thought, oh, this makes so much more sense. It's the way I've always thought, and I'd never had support, or not necessarily support, but understanding from my previous managers about even what that was all about. But then 5 years ago, when I started working at this clinic, our manager got connected with George Fox University and the Providence Clinic in Newburgh, and the Newburgh professors were amazing. Those Newburgh George Fox professors were amazing at mentoring us and starting this clinic. Myself and CJ Zeta were the ones that started this clinic up, and it's just been such a special adventure. I'm very passionate about it.
That's awesome. Thanks so much for sharing that. And can you tell us what health system this is, if you're at liberty to share?
Yeah, I could sure share. This is the Providence system. I work for Providence Medical Group, which is the medical office side rather than the hospital side. So this is where all the doctor clinics are. So I'm embedded in with 12 physicians, primary care providers, which would be nurse practitioners and physicians. And how we split this up, my CJ and myself, we are kind of opposites in our roles. When I'm seeing my own patients in the clinic the half day, then he is floating amongst those providers and kind of on call, per se, with a cell phone. And then I switch with him. So then I have to take the other half day. So he and I are the ones that primarily cover all those providers. And you wanted to hear a little bit about how we work that?
Yeah, absolutely. But I think before we go down that road, I would
Uh-huh.
like to know a little bit more about, I remember several years ago having a meeting with CJ and one other person, and I can't recall exactly who that person was or what his role was, but we talked a little bit about how this operation, PTs in primary care, was started up. So I think it would be awesome if our listeners, if you could tell them a little bit about how this all came to be, what laid the groundwork, what was the thing, the straw that broke the camel's back, if you will, to get PTs in primary care at this setting.
At this setting, I don't think that there was a problem per se there wasn't a crisis maybe that started this. It was seeing that things could be done better. Our manager, Tom O'Donnell at the time, saw that the amazing things that George Fox was doing. And they were, Providence and Newburgh Clinic was allowing George Fox to do that, and those professors to do that. And he got excited and said, I think we should do this in our clinic.
Mhm.
And just saw that it was a better way, a more cost effective way, really providing value and preventing problems from being so chronic by the time we saw them. The old
Mhm.
model of physical therapy where you get a referral and the person waits 2 or 3 weeks to get into a clinic. And by that time, they may have had other become more chronic, or also having some biopsychosocial kind of issues with dealing with their pain, not knowing how to cope.
Mhm.
It becomes much more complicated to treat them. So
Right.
he saw that that was a problem, and that is a problem in the medical system, which we really feel like we're helping with catching things earlier now.
Mhm. And were you around at the time that this got off the ground? Were you a part of any of the conversations when, they wanted to start this up? And what was that like?
Yes. Um, Trying to get the, how should I say? It's very challenging to provide value-based care in a fee-for-service world. And I feel incredibly privileged that Providence had the foresight to recognize that if we continue to bill in fee-for-service and focus on that, this model is going to break eventually. I really think they saw that even though we weren't billing in the traditional way, that eventually this would actually cost less also. And it's a challenging thing to transition from fee-for-service to value-based care,
Mhm.
and recognize that someone's going to have to be the leader with this.
Mhm.
And so allowing our department to do this, I think, is so amazing, because it started other disciplines to be able to do this too in Providence. So I don't know if I answered your question or not, but
Yeah, yes,
the
definitely too. I have some follow-up questions though. So
uh-huh.
when it was originally getting off the ground and somebody had that very first idea, like, hey,
Mhm,
why don't we get a PT in primary care
mhm,
to get patients started earlier, ensure
mhm,
that they're appropriate,
mhm,
encourage more team-based care. Was
mhm.
there any trouble? Was there any pushback, or was it kind of a slam dunk right from the beginning?
I think that our director was respected so much within leadership that there wasn't a lot of pushback, to be honest.
Mhm.
We had a unique way we did the finances with that, and the way we did our clinic on our other half day to make it financially work. Um, and that was challenging on us providers. I'll tell you more details about that when that feels appropriate. But we didn't have to keep doing that, luckily. They kind of made it easier for us down the road. But no, he was so wise in coming up with the plan, and
Mhm.
CJ and I were willing to go with it because we felt it was so important. And it felt like we were starting our own little clinic, really.
Yeah. Yeah. And okay, that's so cool
So,
because it's a theme that has been echoed throughout all of these podcast episodes where I'm interviewing people that have started up these programs.
mhm,
And really, when you're starting up one of these programs, first of all, it takes a good leader, but it also takes really good relationship building ability. And if you
mhm,
already have excellent relationships with others in other departments in a hospital system or in
mhm,
a clinical system, it makes things like this a lot easier. The clinics and the locations, the facilities that have had more problems
mhm,
are, PTs that almost just kind of want to like force their way in, don't have an existing relationship with primary care or urgent care or the ED prior to even starting and just saying, "Hey, we want to be in primary care." And everybody's like, "Well, wait,
um,
why? And can you do this? And do we even know you? And do
uh-huh,
we trust you?" And
uh-huh,
it all comes down to communication, relationships, and just
definitely.
solid leadership. You got to have that
Mhm,
across the board. And if you don't have somebody with a go-getter mindset who is ready to put the lay out the whole strategy ahead of
mhm,
time in a responsible and diplomatic and reasonable way, then
Mhm.
you probably are not going to be as successful. So that I just wanted to reiterate
Definitely.
that for anybody who's listening, that it really does take good leadership and good relationships to get things like
Mm.
this off the ground. I've run into other situations where these types of efforts are not so fruitful, where when you don't have good existing relationships to begin with. Is there anything else that you want to comment on from that angle?
Yeah, I'm just remembering back now to all of the times when we would just ask to be on the agenda for the primary providers staff meetings. And we would come to there and we would, explain and how much easier this would make their life, and how the patients would love having, two professionals brainstorming together in the visit about their problem, and they would feel so much more cared for. And how we could take over their musculoskeletal part of their office visit, so they wouldn't have to do the exam. They could be charting, and they could be listening, and they could be strategizing about where they want to send those referrals or that order for imaging. It just makes the provider's life more at ease.
Mm-hmm.
Um, and once they caught that vision, then more and more started using us
That's
in the provider in the office. So
That's wonderful. So now I have my next, and this is kind of like a perfect segue into for day one that you were in the primary care clinic up there, what type of case did you see? Explain the scenario. Like, how did you get into the room? Is the physician in the room with you? Just kind of go through the very first case that you saw, if you can remember.
I can actually. In the very first case, George Fox, like I said, was so wise. What they did is they brought CJ and I to their Newburgh clinic where it was already running,
Mhm.
and they had us, with one of the professors at the university who was also one of the PTs treating in this clinic. So he basically came on like he was coming to work, and he said hey to all the providers, and I could see he was really close friends with all of the MAs and the medical assistants, and I could, wow, he's just part of the team. It was really obvious. And the doctors really, could tell there was a good relationship there, and I was supposed to shadow him. And I'm just laugh every time I think about this. I'm coming in from another clinic, another state, and he says, oh, I've got 3 doctors needing me at once. You go in with this doctor, and he's great. He knows you, and he knows this process really well. You just head in there. I'll be next door in another. I'm like, what?
Baptism by fire.
Exactly. I walked in, and this physician was just incredible. He said, go, hey, take a look at this patient. What do you think is going on with her neck? And that's what I did. I just literally did my thing, briefly, quickly doing some special tests, and screening for the big bad things, to make sure that this is PT appropriate or not, and just helping him decide. And you could just see the patient loved the teamwork and the interaction between PT and physician. And I
Mhm.
was sold. First time, I just thought, oh, this is incredible. I was so absolutely pumped with endorphins.
That is so nice to hear, especially because there are a good percentage of PTs that are out there where this model makes them a little bit nervous, and it's a little bit they get concerned over the more abbreviated time frame that you have to see a patient, that it's not going to be enough, or that it's just a different setup altogether. So just, do you have any comments for those PTs that are out there that maybe think that it's not appropriate for physical therapists to be in these settings? What do you
Oh,
think about
wow.
that?
That thought had never even crossed my mind. It just needs to be more settings. Um, Boy, I mean, we are the specialist of the musculoskeletal system.
Mhm,
So, I mean, who better for us to be there
mhm,
in those situations, and to helping providers determine, is it musculoskeletal or not? I mean, I've had 3 cases like that yesterday. Is this cardiac, or is this intercostal and rib junction? My goodness, we can save so much headache for the patient,
mhm.
and cost, and worry about for the provider. Yeah, we definitely need to be there. And yeah, we have to be on our game. We got to really know what we're doing and think decisively, um, and know the most important things to test and in the order
Hmm.
to test. Because you're trying not to take extra time from that provider, or they're not going to call you in, right?
Right.
So you
Hmm.
got to be quick. You're not doing this long, lengthy 25-minute evaluation. You
Hmm.
start with the most, the worst thing that
Right.
could happen and kind of work your way back until you know enough to say, is this or that? I think it's this or is that? And basically, do you need imaging, or is this PT, or do we need other workup, or is this a PT related thing?
Absolutely. So in primary care, PTs are really there to conduct a really thorough and very quick and efficient triage.
Yep.
And not all patients are going to be appropriate for PT.
Mm-mm.
At PT, as we as often the rest of the world knows it, where you
Mhm.
go at sort of a higher frequency. But I actually think there's a much higher percentage, probably 90% of all musculoskeletal pain or functional complaints that come in the office, I think we can work with in a shorter period of time than traditional PT has to
Yes,
offer.
definitely.
And we're
Yeah.
missing all of those, you
Definitely, because
know?
they know in their heart of hearts, if we weren't in the office, when the provider would give them a referral offer, they'd say, well, no, I don't think I really need that, because they
Right.
know it's going to be lengthy
And
and
expensive.
basically they needed 15 minutes of my time,
Uh-huh.
right? It's all they needed to get them started
Mm-hmm.
on something.
Mm-hmm.
Um, some little education, or some 2, 3 exercises for them to do, and they didn't need the referral and the, like you said, expensive and lengthy wait and higher chronicity.
Mm-hmm.
um, yeah, well, those people get missed. You're exactly
Absolutely. And
so.
there's also something to be said about the interaction that you have and that touch point, the face-to-face contact, that introduction, the brief, even if brief therapeutic alliance that you're able to establish in that very first visit for patients that really do need PT, like
Mhm.
traditional formal PT.
Yes.
Those patients probably I don't know, you tell me. Have you found that those patients end up coming to therapy a little bit more, when they are able to see you and establish a relationship on day 1, the first time that they come in for a problem versus a
Mm.
physician giving them a referral? So if you can speak to that.
Yeah, I mean, they already, that we call it the warm handoff, basically. I mean, it is a they are already so bought in because we've already helped them.
Mhm.
You don't have to spend the first part of your PT evaluation getting buy-in,
Mhm.
because they already really have seen how it's helped them. They have a relationship. And sometimes my schedule doesn't match the person's, and they don't end up seeing me when they
Mhm.
even come to our clinic. Or we're really good about asking, what clinic would you like to go to?
Mhm.
We don't want to talk about all self-referral. We just want
Right.
to give them the help they need. They may already have a great relationship with someone too. So we're
Mhm.
really careful about asking. But if they want to have somebody, maybe it's me, or I have the opportunity to triage what is the best therapist for them. Maybe
Mhm.
I don't specialize in that part of the body.
Mhm. Yeah,
So we
definitely.
can even help get them to the right therapist in the community, because we're the ones that know. The providers don't know.
Yes, definitely. I love this. And can you speak a little bit to your first experience bringing it back to Providence?
Mhm,
Um it's a new setup,
mhm.
a new sort of process and operation for everybody. How was your presence in the clinic received by the physicians and nurse practitioners that you worked amongst?
I mean, we feel like we're part of the team here. It's really, I think we could even do a better job of continuing to attend all of their meetings and be even better. But, it's important that we're not siloed off in our own little clinic. So, wandering amongst the providers and, connecting with the medical assistants in the morning, and
Mhm.
how's their day look. And sometimes they'll come and tell us, oh, I see this one on our case. I bet you're going to get involved with this one. They can give us a little heads up.
Mhm.
Um, some
Yeah.
providers ask us to look down the list and find which are going to be the cases, and be ready to head into those cases ahead of time. And that is really helpful. I wish all the providers would do that, but we
Yeah.
have to get their permission individually. So each provider has a little different way that they like to do things. And
Hmm.
that's a little challenge to learn. There is an optimal way we've come up with over the years that goes the smoothest, but educating each of those providers to use that optimal way is a little bit of a challenge.
Yeah, definitely. And this comes up too when you are implementing new processes and you're really truly establishing a new culture
Mhm.
amongst the working group and the team
Yes,
dynamics that are there. You're establishing a new culture. And
definitely.
that's difficult for a lot of people when they're used to doing things a certain way. And
Mhm.
I think it's really important if you are going into a new process to respect that
Mhm.
and to understand that, like, just as when we see patients, not every patient is going to be, in fact, no two patients are the same as far as the ability, what they are going to respond to
Mhm.
communication style wise and all of that. It's the same way when you're working amongst a new team. Some providers and some physicians are going to have a certain communication style that's going to work really well, and
Mhm.
other providers are going to need a little bit more time to grasp onto the concept, and maybe they will come to things in time. The
Mhm.
biggest piece of advice that I usually share with everybody is not to be forceful. And
Definitely.
you can sort of have an established guideline,
Mhm.
but having going into it with the expectation that everybody might treat that guideline just a little bit differently, and that it's okay to be receptive to those things, is really the best way that you're going to ultimately capture everybody's attention without people feeling slighted, or people feeling like this is too much for me. I need to take my own time. And so we just treat everybody with respect. And if
Yes.
they're I've heard of other locations or other people saying that they have like some providers that don't use them at all, and they don't even want to talk to them, they don't want to look at them, they don't want to be engaged whatsoever. And it's like, well, those are just not the people that are going to be your champions right off the
Yeah.
bat, and
Yeah,
that's
we have a
okay.
couple of
You
providers who choose not to. All of them have tried, and a
Mhm.
couple of them just choose not to. It's just they have their system and it seems like it's worked for them. And I don't know if they have the vision entirely, despite us trying to present it, but it's not a negative thing,
Mhm.
like it's adversarial. It's just, well, I think I'm going to stick with my strategy that I've used for years.
Mhm.
And
And
that's okay.
that is okay. That is okay. And it is not it's actually, it would behoove you and all, anybody who's going into a new process like that to just respect that and to just be
Mhm.
kind to them. And maybe over time, maybe even it takes years to build up relationships with those people enough that they do trust you. And even if they do internally feel like they trust you and everything, maybe they just want their own process. They don't want anybody else in the room when they're with a patient. They probably have their reasons for that, and all of that is okay, and to
Definitely.
be respected. So
Mhm.
these are really great points. I want to come back to just other you mentioned something early on, that you grew up in a family where holistic and preventive care was kind of the standard, which I actually thought that was really interesting, because I kind of grew up in the opposite. It was like
Oh.
everything just needed some Advil. If you got a little pain, take some Advil. Like the concept of prevention was not something that I was really raised with. Um, so it's very interesting to hear that that is something that you were raised with. So this all made a whole lot of sense to you. Do you want to elaborate on that a little bit, or on what really jives with you about primary care PT compared to what you learned in PT school and your early years as a PT?
Mhm.
Hold that thought. We will be right back. Just a quick break to share a few details on upcoming events at Redefine Health Education in 2024. We'll be back in Salt Lake City in January, 27th and 28th, for our primary care PT hands-on workshop, where participants will get a chance to take a deeper dive into all the critical thinking and hands-on skills involved in a true multi-systems primary care PT assessment. You get a chance to practice things like heart and lung auscultation, use an otoscope to assess the ears, along with vestibular complaints and head and neck pain, take an ABI with a Doppler device, and so much more. You can sign up online at our website, www.redefinehealthed.com. We're super excited for that. We also have a primary care and imaging showcase on April 24th, 2024, which will be live on Zoom. It's called a showcase because clinicians will literally show their cases. We're currently looking for some clinicians that want to take 15 minutes to present a primary care or imaging related case. You get to share your knowledge, hear other cases, and get some presentation experience. Or you can just sign up as a clinician to soak it all up. It's only $25 for 2 CEU contact hours. And a recording will be made available if you can't attend live. Thanks so much for your support, for listening to our podcast. And don't forget to hit that subscribe button, please. Thank you. It helps us so much. Share the word about our podcast with all your friends and pals and colleagues. And now we'll get back to the show.
Even though I'm in the allopathic system, I feel like PT is a little bit more maybe like alternative care in maybe naturopathic or functional medicine kind of realm. Really, we're in the allopathic system, but yet we focus on prevention. Yes, we treat things after the fact, but I think most of us think about, at least I like to think most of us think about, how could we prevent this from happening again?
Yeah.
I sure have always thought that way. That's just the way my brain's wired.
Mm-hmm.
And just growing up in a family, which was, more of a naturopathic family. And I actually thought about going into naturopathic medicine and took some classes with that. And so I actually have kind of live in both worlds. I feel very comfortable talking about dietary things, herbal suggestions for decreasing inflammation, ways to get better sleep, all the pillars of health. And our current manager is mandating that we give everybody that opportunity to work on prevention. Says you can't assume that someone just wants the Band-Aid to get better from this one thing unless you've asked them.
Right. Absolutely.
I think that is beautiful. Maybe at one time you maybe only catch about 15% of people, he says, that really want to go grassroots and find out what the problem is that caused this, so they don't have to keep coming back over and over for different musculoskeletal complaints. At one point, about 15% of people are really ready to make that one big change with readiness to change models, right? But how do you know who those are? You shouldn't judge it. You should ask them. And so that's how I've always kind of thought. But now we have a manager that supports that. And so it's wonderful. The last 3 years have been wonderful for that reason. He's a really amazing. We got someone who had the vision to start it and start this here. And then our next manager even had more kind of accessory additions to that with the mandate to ask all of us to really focus on preventative care.
Isn't that something? And I find that even so I've been a PT for almost 10 years now, so not too long, but not too short either. And I just feel like when I very first started PT school, maybe even beforehand, my thought of what physical therapy was just rehab, like you have an injury, you already have a problem, and you're seeing me to help you with that problem. And and the literature, just scientific papers, that the focus when I first started as a PT, I felt was more on, like treatment-based classification systems for diagnoses and treatment for problems and so on and so forth. But I was exposed to, we probably should pay attention to, pain-related behaviors and those things too. But then I've noticed this just surge in the past 5 years, especially this surge of, we actually know now that systemic inflammation is a huge contributor to the I'm just going to say global dysfunction of the nervous system and the autoimmune system. The neuroendocrine systems, all of these things function together. And we know now that systemic inflammation is heavily, if not almost sometimes exclusively, influenced by lifestyle behaviors and sleep quality and, the relationships that you're exposed to that are maybe very stressful on a day-to-day basis. And, that's the root of a lot of people's problems. And if we exclude that from our conversations with our patients.
Yeah,
Of course
exactly.
we want to get their consent, just like you said, we want to get their consent to go down those roads, because some people are not ready to go there and
Yep,
some people are not ready to change. We have to do an assessment of their readiness to change. Um
exactly.
but if we exclude that just because we assume that nobody wants to perhaps improve their diet or start exercising,
Exactly.
that's on us.
Yep.
That is on us.
Mhm.
And I think that is truly the heart of the difference of PTs in primary care, but
Yes.
really PTs anywhere, just taking that primary mindset where we can focus and work on patients with prevention and
Mhm.
talk to members of their healthcare team about, hey, this person has this problem. I really think that if they get their sleep and their anxiety under control better, then they would have better success with their pain management. What do you think? What are some options that I'm not thinking of? And I think that's a
Exactly.
great way to bring the team together. And man, I just love that you said that. And I love that you have a boss that is promoting that now. It's really refreshing to hear.
No, we talk about fall prevention. Why can't we talk about diabetes prevention and
Yes.
depression prevention? And,
Mhm.
there's so many other areas we already think about prevention in some regions and, falls especially. Let's just
Totally.
keep expanding that as a,
And so I have a question then. So if in prime when you're seeing patients in primary care, are you sort of exclusively utilized for musculoskeletal issues, or are you also seeing a little bit more patients who have depression who might benefit from exercise therapy? Or same thing with diabetes, like these other non-communicable or mental health disorders that would benefit from exercise. Are you seeing any of that coming through primary care?
I would say that's just beginning because the providers are starting to maybe through repetition kind of catch on to this. The areas that we think we have grown in. I've gone in and done combined pelvic examinations because of my pelvic health background. So we're kind of upstream doing that with a couple providers, to help, prevent worsening incontinence or things right after childbirth. We're doing some fall prevention, but yeah, the areas to, all right, we're doing general deconditioning, people who are heading down or have a really sedentary and really unhealthy lifestyle. We have someone who's really interested in weight loss work, and so we're being used in that way. But I think there's way more areas of continued opportunity, mental
Hmm.
health, diabetes prevention, not just for general deconditioning, but people that are headed down that diabetes route by their labs, we can prevent this from happening or even reversal sometimes, depending on if they're type 2. Yeah, there's a lot of areas that we could still grow. We need more PTs, to be honest, because we don't have enough hours if we
Definitely.
grow that too much. So that's what we're trying to do now is work on our financial models and expand this to other buildings in our on, we're already in internal medicine, orthopedics. We're trying to become more fully embedded in urgent care. We run over there when we have time to urgent care, and it's in a different building on campus, but we would like someone over there all the time. Um, there's areas for growth, lots of areas.
Definitely. And I love that you're already identifying what the areas for growth are. So now on that note, and just kind of as we wrap up here, I know that, the $1 million question, or should I say the billions of dollars question, is the financial model. So how are you financially sustainable with your presence in primary care? And do you see that changing at all in the future?
Well, we're actually just just transitioning. So it's excited. It's been a 3-part thing. How we first did it is, like I said, I'd be in the clinic for 4 hours in the morning and I'd seeing my own traditional type PT clinic patients. But how we did it to convince the providers that this would work and is we would see 2 patients on each hour. And we had an exercise, a really highly trained um, athletic trainer exercise. We used them as a highly trained tech. And the 2 patients would start on the hour, and I'd plan ahead who was going to start with the tech and who was going to start with me. And then we'd flip flop. So we'd have 2 on the hour. So by the time the day was done, we'd already have seen the half day was done. We'd already seen 8 patients, which was enough to pay for us with that, plus the few single charges that we charge 1 15-minute unit when we see a patient on the doctor side,
Mm-hmm.
on the primary care side. So that was the model that convinced them, yeah, we're not risking anything financially, so let's go for this.
Mm-hmm.
And then our next manager came on and said, boy, this is tough on you guys though. He got 8 charts to do, and then you go into your on call, and if you have a day that's low, you catch up on your charts, but if you don't, so it was intense, and we did that for
Mm-hmm.
years, and it was, I'd still would, if you have the right tech, it works.
Mm-hmm.
But it was intense.
Yeah.
We figured out that we didn't quite have to do that because Providence was willing to basically float a half FTE for myself and half FTE for my colleague, and basically paid for 2 more years of paid for that one salary. Just knowing that this model was so important. So that's really kudos to their amazing insight into how this would help.
Yeah,
long term.
that's
It's
awesome
huge.
to hear that Providence was good on that. And I know the Bellin Health System also does something like that. They kind of are non-revenue generating while they're in primary care. Um,
About a quarter of
and
revenue is what it would be, a quarter of what it would be, I think. Because it's
right. And
one
so
unit instead of 3 or 4, per interaction, basically.
and are you doing those as independent PT billing codes, or is that incident to the provider visit?
It's an incident to the provider visit, and
Mhm.
we are the service provider, and we let them be the billing provider. So we give them credit. So that also helped. I think even though it's a tiny little bit of money, but the providers got credit for that, those RVUs, the way we did it.
Okay. And so another angle to look at this from, because I see this happening all the time, is, we're the isn't this what always happens? Like PTs sort of get the short end of the stick. Um, and while it's good, we're always willing to do things to help our patients and to do the right thing. It almost seems like whenever we do these things, we have to over justify it to financial, to the other providers, to make it look better for them. But we also have to remember what's in it for us.
Mhm.
And I just
Well,
hope
that's
that
the
anybody
last
anybody
stage.
who's yeah, anybody who's thinking of starting this up, make sure that you're not putting, yourself or your PTs in a sticky situation that will ultimately not be the best for them either.
Well, that's the
Um,
last stage that we're in now, to be
mhm.
honest. Do you mind if I take 3 seconds to tell how we're doing?
Please, please.
So just this year now, we've given you this free, amazing care, and you see the value of this. Now we ask you to pay our salary.
Hmm.
So, and that's what we're actually negotiating right now
Hmm.
for this next coming year. So it's exciting to have, the medical side rather than our PT department going to be paying for this one salary. That's what they're negotiating, at least. So we'll see how it turns out. It's in negotiation right now. It may end up being, I think it's going to end up being more of a shared situation, but hey, 50-50 is a lot better than 100%, right?
Hmm.
So if they do that, that's saying we see the value and we're willing to pay for it.
Right.
And
Definitely.
that's what I'm excited, but they've seen it for 5 years now.
Hmm.
And I think that's the way it's going to ultimately go, because
Yeah, and I do think that there with new processes like this, if you really want to make something happen and you want to do the convincing, it's
Mhm.
you give a little in order to down the line get a little. And that's exactly what we're seeing happen with advocacy efforts for practice expansion. So like ordering imaging, for example, I know there were certain states where it was sort of a give and take. Like they were going to say, okay, they started off, well, let's do all imaging modalities because it doesn't even make any sense to do one. That's my personal opinion after ordering imaging for my entire career. Um, why are we just doing radiographs when we would need to follow it up with another imaging modality after reviewing the radiographs anyway? That makes no sense. But sometimes in certain states they kind of have to do that just
Yep.
to demonstrate that they are proficient in that, and then down the line then they can ask for a little bit more. So it's kind of a similar principle where just because that what I'm trying to say here is negotiations and diplomacy is really, really, really
Yes.
helpful in these circumstances.
I agree
Mhm.
very highly.
Yeah. So yeah, just as we're wrapping up, is there anything else that you want to talk about or want to share? Any cases, any advice for people who are interested in starting this up? Or just anything?
I think the thing I'd like to speak to is the physical therapist who's wondering whether they would enjoy this. Um, when we get to work at the very highest part of our license, which is our examination, that makes us the most excited. At least for me, counting repetitions in the gym or charting long, lengthy things is not as exciting as quickly doing assessments and helping and directing and triaging, which is our evaluation. And I find that that is really recharging and energizing. And I don't know, I just think it's a lot of fun. So I
I
encourage you to try it out, look at, learn it, see who's around you, go shadow, see what it looks like to you. We have students coming through here all the time that want to learn this. We have a waiting list where you call ourselves a teaching facility because we have students who are coming and they're only accepted if they want to learn about this model. We have
absolutely.
one in the clinic at all times, and there's 4 of us, so 5 PTs with 2 of us being half FTE floats. So that's how the model works here.
And I will speak from my experience. I was a brand spanking new grad. My boss at Fort Sill put me into primary care within 3 months of starting there. And I kind of didn't know what I was getting myself into, but I can tell you this, that I got really, really good, really, really fast.
You have to.
Because you have to.
Yes.
If you're seeing that many initial assessments where you have to make the decisions, you get really, really good, really, really fast. And then the concept of, counting reps in a gym, like that's why we have techs. I mean, that's not what we're skilled and trained to
Exactly.
do.
Yep.
So if you're a PT out there and if you think this is for you, then if you're out, on your own, you can always call up a primary care office and see if you can do some shadowing hours. Again,
Yep.
establishing that relationship first, building that relationship, maybe throwing in a little bit of hey, did you think of this or that? Like when you're not with the patient. And then if you're in a larger health system, just, go have lunch in the primary care clinic, see if they want to come down and see the PT clinic, build
Exactly.
relationships. And that's how you will ultimately get to work together better for the patients. That's my opinion.
I agree.
Mhm.
Nicely said.
Yes. Well, thank you so much for coming on. If people want to reach out to you, what's the best way for them to do that? I can also include that in the show notes.
Sure, they're welcome to reach out. My first name, Rachelle, Rachelle, .Hartman at providence.org. So Hartman.
Got it. And I will put the that email address in the show notes if anybody else wants to reach out to Rachelle. Thank you so much for coming on the show.
Well,
And
thank you for what you do, Katie. Yes, thank you for being a pioneer. You've probably been doing this longer than any of us. So
I don't know about that, but I've been doing it for a while, but my whole purpose is to get this message out so that people
yes.
understand that this is possible. And I really
Mhm.
do believe that it's the future of what will make our profession sustainable in the long run.
Yes,
And it's really the best
definitely.
thing for patients anyway. So,
Exactly.
all right. Happy
Thanks
holidays,
for having me.
everybody.
All right. Bye.
And that's a wrap. Thanks for listening. If you love our show, go ahead and subscribe to stay tuned for future episodes. As a thank you to our listeners, we're happy to offer $50 off of our Primary Care PT Foundations course or our Musculoskeletal Imaging certification. Visit us at redefinehealthed.com and use code PCPTPodcast, all one word, all lowercase, on the checkout page to claim your discount. That's PCPT Podcast, all one word, all lowercase. Until the next episode, stay awesome, y'all.